So today I'm going to present on prenatal diagnosis of arteriovenous malformation and its outcome. From our center, I'm presenting this on behalf of our team. So arteriovenous malformation presents as a hyperdynamic circulation in fetal life. We have seen a lot of extracardiac AV malformation after birth, but this is one of its own kind study where it was diagnosed during fetal life and we are presenting its outcome. It can be mild chamber dilatation due to cardiomegaly, and some of these fetuses can develop hydrops. Suspicion should be made at fetal life, and further evaluation and follow-up should be done so that timely treatment can be given. So we have 6 cases starting from placenta to head. There are multiple level AV malformations which are seen, and the gestational age at presentation ranged from 19 weeks to 32 weeks. And all of them majoritarily have the cardiothoracic ratio, which was more than 55%, and that's why they were referred. None of them developed hydrops in our study, and some of them had pericardial effusion. So my first case is 32 weeks gestational age, which was a known case of chorioangioma, but referred to us at 32 weeks. And we can clearly see that there is a cardiomegaly, right heart is dilated, there is aneurysmal foramen ovale, which is almost closing. The ductus venosus and the umbilical vein is dilated. There is a cardiomegaly. And we can see that there are multiple large chorioangiomas in the placenta, and we can see that there is a there is an increased cardiac output and increased return from the umbilical vein. And the last one is the stick image of umbilical cord, where there is a hyperdynamic circulation leading to that kind of situation. So this child, because of premature closure of foramen ovale and because of this kind of hyperdynamic circulation, was delivered at 34 weeks. And we can see that the umbilical cord has been completely varices formation. It is dilated, and this is the cut section of placenta and the external appearance of placenta showing that there is a chorioangioma. So this baby required few days in NICU stay and got discharged at 1 week of life. This is the next baby, 24 weeks of gestational age. There is a dilated right heart, and IVC was dilated with z-scores of plus 2.6. So that was our first clue that why the IVC is dilated. And then we can see that there is a turbulent flow coming from the descending aorta and entering into the hepatic vein and then going back into the IVC. So he was diagnosed with the hepatic AV malformation, and we can see that there is a continuous Doppler at that level. Then this is the next case who is presented as sequestrated left lung, and because of that there is a dextroposed position of the heart, and that's why he was came for evaluation. The cardiac chambers were looked normal here. SVC IVC flow was also normal, but again there is a large collateral seen from the aorta and entering into the lung parenchyma. This is again a stick image which shows that there is a collateral which is coming from the descending aorta and entering into the sequestrated left lung, and that is the continuous Doppler of that artery. So this child was delivered, and we can see that there are multiple collaterals coming from descending aorta and entering into the left lung. And because of the high cardiac output state, it was closed at around 6 months of life. This is the next case who presented with right heart dilatation. And we can see that there is a turbulent flow in the first image entering into the right atrium. And we can see that from the aorta, there is a channel which is arising and then entering into the right atrium. And then there is a continuous Doppler to it. So this was diagnosed as coronary AV fistula to right atrium, intrauterine life. So after delivery at 15 months of age, there was noticed as cardiomegaly and left ventricular forces were enlarged. We can see that there is a coronary AV fistula from the right coronary artery entering into the right atrium that confirmed the postnatal diagnosis, and it was closed electively at 1.5 years of age. So again, the angiogram confirmed the diagnosis that there is a coronary AV fistula to right atrium from RCA. And post closure, child is doing well. This is a next case. This is one of the twin. There was a chamber discrepancy between the two twins that was seen, and he was just referred as a routine evaluation for twin pregnancy and IVF conception. We can see that there is a cardiomegaly. There was both babies. If we compared, this heart was looking bigger, and that's why we started tracing that why it is like this. So we traced from brain to abdomen, And we can see in the, this is a neck part of the baby. There was multiple channels were seen, and this is a continuous Doppler at those multiple channels, which confirm that there is a cervical AVM. Unfortunately, at 2 weeks later, only this fetus had IUD, and other fetus continued pregnancy because it was a DCDA twin. So this is again a case of referred as a cardiomegaly, and we can see that the right heart is dilated. And this is the next picture, which shows that there is a SVC dilatation. And as we have a protocol to rule out AV malformation, we started scanning from head to toe, and we found out that there is a vein of Galen malformation. There is a continuous Doppler. These are the beautiful stick images which are showing that there is a AV malformation from middle cerebral artery. So in conclusion, AV malformation can be diagnosed by subtle clues like cardiomegaly, inappropriate chamber dilatation, or draining chambers and draining vessels. The HD color Doppler and E-stick will aid to the diagnosis. And of course, the color Doppler and the pulse Doppler at that particular level also helps in the diagnosis. Fetal counseling and level of understanding the problem by the parents for the counseling is very important and will decide the outcome. So thank you so much.